Good evening, everyone. Welcome to the webinar on Navigating Treatment Choices for EGFRm NSCLC. It gives me great pleasure to invite our program director, Dr. M. Vamshi Krishna, Head of Department and Director of Medical Oncology, AIG Hospitals, Hyderabad, to introduction and opening remark. Over to you, sir.
Good evening, everyone, and welcome to this interesting meeting on mutant EGFR-positive NSCLC. I think like all of us who have been treating lung cancer for the past 15 years, this topic was unthinkable 15 years back. We didn't have anything much to do with lung cancer. But in the last few years, there has been an explosion of knowledge, drugs, and again, more interestingly, what new drugs to use for mutant EGFR in NSCLC. So today we are honored to have Dr. Luis Perez with us. He really needs no introduction. We have been hearing his name and listening to his lectures for the past several years. So the flow of today's meeting will be a short discussion on the role of liquid biopsy and biomarkers by Dr. Santosh Chellapuram, followed by the lecture by Dr. Luis Perez. And we would like to have some question and answer and then a small case-based discussion on how we manage this type of disease in India with, of course, the inputs of Dr. Lewis as well. So I think without further ado, I would just hand over the mic to Dr. Santosh Kumar for the next session. Dr. Santosh is a good friend and a senior medical oncologist at Star Hospitals, Hyderabad. Santosh, over to you.
Yes. Sophia, I would request you to share my slides, please.
Yes, sir.
I will just
Yeah. Good evening, everyone. Thank you, Vamshi sir, for giving me the opportunity. Yes, the point well taken that this meeting was unthinkable maybe 10 to 15 years back. So we are in the reality, and let's discuss how the concepts in terms of targeting mutations have evolved over time. Meanwhile, my slides are loaded. So how the things are evolved from histology agnostic approach where we do not have anything upfront. Next slide, please. So whenever we started the era of lung cancers like one, later what happened is the histology agnostic approach have moved to an era where we treated based on the histology. Thank you. So later we did a lot of immunohistochemistry. Later comes to the era of NG, NGF, and multiomics. So as we all know, targeted therapy directly acts on the oncoprotein which is mutated, whereas chemotherapy acts on good and bad cells, as a result of which we have a problem. Next slide, please. So this is an interesting study that was published by Smith et al. In ASCO 2022. They have divided into three groups: Group A, Group B, Group C. Group A is tested and treated with TKI after genomic profiling report within as early as possible without any prior use of non-TKI. Group B is, yes, they started with broad chemotherapy, later shifted to TKI within 35 days. And in the group C, after 35 days, they have given. As you can see, earlier we start, the group A has predominant significant improvement as compared to the group that haven't started. So this also emphasizes that the earlier we start with the best agent, it's more better rather than giving some non-specific agents and shifting to TKI. Sometimes in real world, we find where the disease burden is very high, but always the data from almost 9,000 patients have given the hypothesis that earlier we start TKI, the results are better. So testing must be fast, accurate, and it should give us good results. Next slide, please. So also it is very important that testing should be comprehensive. As you can see here, there is separation of the curves in terms of OS when testing was comprehensive in compared to incomplete testing, which was only 2 to 6 gene testing or no testing performed. And why it is important is we need to identify all class 1 alterations. And also in cases where the tissue is inadequate or adenosquamous, we also tend to do in that scenario where we know that there are emerging targets for treating of KRAS G12C mutations, which were untreatable previously, and the HER2 mutations and amplifications that were not properly treatable. So Testing should be fast, number one, and it should be comprehensive. Next slide, please. Also, whenever we see, we have to reduce the turnaround time. That is possible with parallel sequencing. With the use of next generation sequencing, we can get faster results. And with limited sample, we can achieve more than 95% success. Owing to the NGS technology, the costs have coming lesser and with more sensitive and accurate result. Previously, the older generation technique like PCR, Sanger sequencing, FISH, immunohistochemistry, and reflex testing are not very useful in the current generation. Yet, we find useful in certain scenario for testing for where we have IHC, where we can get the test earlier. But NGS gives us a comprehensive assessment with early, with limited tissue, and with a more sensitive and accurate. Next slide, please. So, as we know, why NGS is important is why not only we can end with PCR, IHC, and anything. Here is a study that has evaluated the detection of exon 20 insertion. We know exon 20 insertion is one of the rare type of exon EGFR mutation where it doesn't respond conventionally to other TKA as response to 19 and 21, where by NGS, 38%, almost 40% of these exon 20 insertion mutations out of 100 variations are detectable NGS, which were not detectable by PCR, which do not perform NGS. Next slide, please. So the other coming is the NGS testing should be comprehensive. That should include RNA testing also. As we know, RNA testing is very much important for identification of fusions that helps in identification more effectively, and it will not miss more fusion variations for which we have very good drugs available with prolongation of the life to more than 5 years. Next slide, please. So here is an important analysis that was published in a National Review of Clinical Oncology in 2019, which showed that there might be false positive, false negatives by doing FISH or IHC alone, and comprehensive NGS with RNA sequencing. If we do, the positivity increases. As you see in far left towards the graph, in terms of ALK mutation, when we do DNA plus RNA sequencing, the possibility of detection of ALK, MET, and RET and ROS1 is very higher compared to only DNA only sequencing. The blue dot that are lower, the diamond dots, where we can miss the mutations. When we do DNA plus RNA, there is scope that we can detect all kinds of mutations. The additional yield is 100% whenever we do use of RNA NGS for fusion. Next slide, please. And this is another area of interest. Sometimes we know EML ALK4. There might be variant rare partners. If we use the universal primer, it might miss. We have to use gene-specific primers, and it helps in identification of rare genes and also rare partners and rare mutations. There is a say AGK-BRF is a fusion in a patient with EML ALK4, which is a potential resistant mechanism to ALK inhibitor. Next slide, please. This is an important study. Patient post-osimertinib, whenever they are progression, we should carefully evaluate. This is one of the case which shows rare kind of BRAF fusion, which responded to combination of osimertinib and trametinib after progression of osimertinib. As you can see towards the far right, the cell viability whenever you use osimertinib plus trametinib, the response rate is higher rather than using one agent alone. Next slide, please. So this is another rare kind of red fusion with CCDC6, where single agent osimertinib or pralsetinib is not useful. Combination of osimertinib with pralsetinib leads to tremendous response rather than using a single agent alone. Next slide, please. So this is another area that we have to understand, the rare fusion, that is MET fusion at initial diagnosis, where we should use a combination that targets the MET alteration, and also we can use in this scenario crizotinib that helps in better improvement in prognosis. Next slide, please. This is a rare mutation that I've learned today preparing to the slide, the LTK fusion that is present in 0.4% of the cases. If we see the number, it is 0.4, but 7,500 cases are detected annually of NSCLC harboring LTK fusion worldwide. The importance of LTK is it has 80% homology with ALK and 100% AA homology in the ATP binding pocket. Yes, so whenever LTK fusions are there, this has a potential to respond with ALK mutation. So LTK fusions have a homology 80% with ALK, but the ATP binding pocket has almost 100%. Towards the right side, you can see the spectacular response with the ALK targeting with lorlatinib after 3 months in the patients with LTK fusion. Next slide, please. So, as we know, we divide our treatment in case of mutation positive. We use a TKI, survival increase to more than 5 years, especially in case of AL. In mutation negative, we tend to use immunotherapy based on the level of PDL1. I choose a level of more than 90% where I am okay to use immunotherapy if they are smokers and all, and either combination immunotherapy. The important point is the TAT should be less than 10 working days for getting of all the molecular markers. This is the benchmark that the guidelines recommend so that to give the best practices to our patient. Next slide, please. So next coming to the area of liquid biopsy. Always it's very, very important to have liquid biopsy where it is not a standalone test. Always a combination of liquid biopsy with solid biopsy whenever we use. It gives us more extra yield, and also liquid biopsy gives us one important thing, the spatial and temporal heterogeneity. Sometimes the solid biopsy might miss. So liquid biopsy, faster sampling, easy tissue, but it is more expensive. Thanks to the increased availability of liquid biopsies, the cost is decreasing. Next slide, please. Also, many times whenever we use the tissue or liquid biopsy, does the allelic frequency matter? This is an interesting study that has done in a tier 1 mutation, irrespective of allelic frequency, when there are more than 50% or less than 50%, more than 80% or less than 40% or less than 1% or less than 0.01%, if the tier 1 mutations are present, it implies response. The response is irrespective of the variant allelic frequency. If we have an EGFR alteration that is the exon 19 or 21 L858R with 0.01 also, it is considered significant because it being a tier 1. This is what is shown in his AACR 2020 publication by Kumar et al. Next slide, please. So we have moved from single gene testing to multi-gene markers such as tumor mutation burden, mutational signatures as are HRP, and microsatellite. So from this, we have evolved to an area of multi-gene testing and drawing analytical improvement by analysis of various markers. Of late, we have moved to the era of using methylation signature also. Next slide, please. So this is a study evaluating almost 4,000 adenocarcinoma lung, where 30% have shown to have rare or non-canonical, out of which 5.6 are potentially treatable. So the rare and non-canonical variants can be identified by doing comprehensive genomic assessment, that is CGP, which includes RNA fusion detection also. Next slide, please. This is very, very important that nowadays the interpretation of the NGS reports is sometimes difficult. So we should have a molecular tumor board comprised of individual action potential to devise the mutation into SCAT recommendation, tier 1, tier 2, tier 3, tier 4, tier 5, and tier 8, so that we can advise the patient accordingly. If you see SCAT evidence level tier 2, we have clinical trials, and 3 and 4 have preclinical trials. If it's category S, the variation is not pathogenic. So we are interpreting data of the mutation to clinical application. Next slide, please. So molecular tumor board, whenever we treat a patient by taking inputs from the molecular tumor board, you can see the overall survival difference. So it helps in very interpretation of the complicated results of MDS sometimes we have and don't understand. and it results in improvement in overall survival. Next slide, please. So we all know IHC for HER2 is evolving with the use of trastuzumab deruxtecan. We know that this is much more complicated than we think of, and we have to evaluate much more stringently. Next slide, please. So fish, yes, in MET it helps, but it could be combined with RNA, NGS also for more analysis. Next slide, please. So this is a very, very important abstract that I have found, where interpretation and inclusion of artificial intelligence in choosing the right biomarker. This is the continuous quantum substrate during the study of Tropic and one study by datopotamab deruxtecan, where they have taken the image of the slide and fed into the AI, and they have calculated the QCS score and told whether this is any predictor of response. What is the importance of this QCS scoring is it identifies whether the TROP2 receptor is present over the surface of the membrane or cytoplasmic. It takes a ratio, NMR ratio, and it gives a scoring based on it. As you can see, based on the histology, if conventional histology TROP2 testing towards the left and towards the right side, if I employ artificial intelligence QCS scoring, in Tropion 2 study, you can see the hazard ratio are improving. If we use conventional cytology only, the hazard ratio are higher. Whereas if we use the QCS data and treat accordingly, the hazard ratios have improved to 0.52. In those, they are negative. Whenever the QCS is lesser, then the benefit with datopotamab deruxtecan is not there. This is how the field is evolving with use of artificial intelligence. It is depicting the cytoplasmic versus membranous and also the intensity of chaining. And each individual cell is collated into a pixel, and voxel data is analyzed. And this is how the field is evolving with utilization of artificial intelligence in choosing what molecule to take. Next slide, please. This is an entity that we know of whenever TP53 mutation is associated with other targetable mutations, especially EGFR and R. We know that the response is lower and we tend to add on chemotherapy. That is what the FLORA2 data showed, where this mutation can be slightly overcome by adding off chemotherapy rather than single agent. So it is a Q mutation, co-mutation that is occurring along with EGFR that helps us in predicting the response to treatment. Next slide, please. So in this Poisson data and Triton data, the presence of STK11 and KEAP1 mutations, we know these are mutations that have resistance to single agent chemotherapy, immunotherapy. So in this scenario, addition of CTLA4 blockage improves the response rather than single agent immunotherapy. Whenever STK11 and KEAP1 are present, no to single agent immunotherapy, and possibly using a combination of dual immunotherapy with CTLA and PD-1 blockade should be employed. Next slide, please. So this is an interesting study, the COAST-2 study and the PACIFIC-9 study, where can we do anything beyond PD-1, PD-L1, and CTLA axis? This is a study that evaluated using signatures from NKG2A and CD73 profiling, combination of newer immunotherapy along with durvalumab, which showed addition of the drugs targeting other checkpoint inhibitor pathways, that is NKG2A, CD73 improves more response rather than single agent durvalumab. Also, we have data with TIM3 inhibitors and LAG inhibitors that improve the response. So rather than using single agent based on NKG2A expression and CD73, we can super select those molecules using dual agent immunotherapy. Next slide. So based on my presentation, the field of choosing accurate markers has evolved from simple immunohistochemistry to the latest AI-based computational platform, where we are able to analyze individual voxel of the slide to derive the things that could be useful to our patients, so that we could give the predictive, prognostic, and also give them proper drug at the right time with a comprehensive analysis. With this, thank you for the opportunity given to me. Thank you, Vamshi Krishna sir and Kavina organizations for this. Apologize for the initial technical glitch. Thank you once again.
Thank you, Dr. Santosh. I think there's a very, very comprehensive and nice review of all the mutations present. And it was nice when we had only one EGFR. Now we have plenty of new molecules and you seem to be stumbling upon more and more of them. Add to the AI, and I think our natural intelligence has just come down and down more and more. So thanks, Dr. Santosh, for that lovely lecture. We'll reserve questions for later. And I would encourage all the audience to please type in your questions. We can have a Q&A session with Dr. Lewis once his talk is over. So I would request the speaker, Dr. Lewis, to please start the session. He really needs no introduction. Dr. Lewis is the head medical oncologist at Madrid. And over the past several years, we have all been reading his papers. He has been a PI in several trials, and he has been a great speaker and orator for so many years. So without much further ado, Dr. Lewis, over to you.
I think it's okay now. Okay. So thank you very much, Dr. Krishna. Thank you very much for this invitation and the very nice introduction. I really enjoy the liquid biopsy conference as well. So over the next few minutes, I'm gonna focus on the evolving management of advanced EGFR-driven non-small cell lung cancer. And for that, I'm just gonna start with providing you my disclosures. And I'm pretty sure that has been mentioned by Dr. Krishna at the beginning. If that was a couple of decades ago, I don't think that very topic would have made sense because it didn't exist at all. It was precisely there in 2004 when actually 3 American groups discovered the EGFR mutation as an activating and really driving the tumor initiation and progression event. And more importantly, they were discovering that those activating mutations were key for the activity of EGFR tyrosine kinases. Indeed, we know that much, depending on the geographical region, the prevalence of EGFR mutation are somehow a bit different. It's about 15% of non-small cell lung cancers in my country. It's going to be maybe in the range of 35 to 40% in East Asia. So, of course, there are some variations. What it is very clear is that most of the patients are responding. When we were studying the initial TKIs, the first and second generation, we realized that about 60% of the patients were responding, but with the time, most of the patients were actually progressing. We discovered by doing some biopsies on those patients progressing that in half of the patients, there was a secondary mutation, the so-called T790M mutation, that was actually responsible for a change in the configuration of the ATP pocket so that those TKIs, first and second generation, they were not binding anymore with affinity and therefore were not useful anymore after this secondary mutation. Indeed, when novel TKIs trying to adapt to the new configuration of the mutation of the ATP pocket were used, in preclinical models, they were actually showing to be pretty effective, those third generation mutations. And actually, there's some trials on T790M mutated tumors were quite relevant, showing that those third generation agents such as osimertinib were a lot more effective as compared to standard of care platinum-based chemotherapy. And you see here the result of the trial at the time conducted by Dr. Kumar. It was then sensitive to say, well, if those agents are able to do progressing patients to first and second generation TKIs to respond, maybe first generation TKIs should be the standard of care. And actually, That was what the FLARA trial was actually proving. Patient that was in the first line without prior treatment with EGFR mutant non-small cell lung cancer were randomized to receive a second or first generation TKI as compared to osimertinib, and the results were very clear in terms of PFS, improved PFS with a hazard ratio of 0.46. That means you're decreasing the rate of progression in more than half in this all over the period of observation. And in terms of survival, the results were actually very consistent with improved survival with a hazard ratio of about 0.7, as you see here in this mature data. Based on that, I think today we admit osimertinib is very much the cornerstone of the treatment of advanced non-small cell lung cancer. Indeed, from those results of the FLORA trial in stage 4, some other studies have been conducted in early disease. The LORISE trial in the stage 3 setting and the ADORA in the early stage disease in resected patients. And in all settings, you see a clear improvement in early disease setting as well, not only in stage 4, for those patients treated with third generation inhibitors with osimertinib. And today, no doubt, this is the standard of care. Unfortunately, if you look at the results, still patients treated with osimertinib, after some 20 months, they tend to progress. For that reason, another type of strategies have been studied trying to improve the results. Today, we may say that other third generation have been developed. I don't think there are clear difference between the available third generation, and indeed lazertinib and fumonertinib have shown in not very, let's say, robust trial, but they suggest the efficacy is very comparable as compared to osimertinib. More importantly, a number of studies had tried to improve the efficacy of osimertinib alone. They have compared osimertinib with other agents, such as in the first attempt with anti-angiogenics. With anti-angiogenic, we have seen a clear improvement in PFS, not that clear in OS. The second study has been more effective. Indeed, the combination of chemotherapy plus osimertinib is being shown to be more effective as compared to osimertinib alone. You see here the result of this FLORA2 trial, where osimertinib is compared to chemotherapy with osimertinib alone. And you see here, osi plus chemo are doing better as compared to osimertinib alone with a hazard ratio of 0.6. So that means you're avoiding 1 out of 3 progressions on the control arm. And indeed, the results are pretty relevant. All the subgroups seems to benefit, and importantly, the benefit is true regardless the type of mutation, exon 21 or exon 18. And more importantly as well, the benefit is at least as good, if not better, in patients with brain metastases at baseline as compared with patients without brain metastases. Look at that, the hazard ratio being 0.47 for those with brain metastases as compared to 0.75 with those without baseline brain metastases. Very important maybe to take into account in our clinic. The initial data suggests that the second other outcomes, the time-related outcomes such as PFS, time to subsequent treatment, PFS2, and so on, there was a benefit in the chemo plus OSI arm as compared to the OSI alone arm. And indeed, the interim analysis survival was also showing some benefit for those patients treated with initial combination as compared to OSI alone. Indeed, we have now clear data, mature data on the FLORA2 trial for overall survival with a median, a good follow-up, and the median survival being 47 months with chemo plus OSI as compared to 37 months with OSI alone. You see here, that translates in a clear improvement in 4-year survival, 41 versus 49%. Maybe the more important data is here, hazard ratio 0.77. That means you're avoiding 1 out of 4 deaths that you see in the control arm with OSI alone all along the study period. That is very important. So you're not only improving the PFS and other relevant secondary time-related endpoints, but indeed, patients are living longer. Indeed, when you do the 4-spot analysis, it looks like every single patient is benefiting regardless type of mutation, regardless having or not brain metastasis. And something that is very relevant to me, at least, you look at the exposure to the agents. Look at that. I mean, the median exposure to chemo, as expected, is only platinum chemo is only 2.8 months, it's 4 courses. But the median exposure to pemidricid in this trial was about 8 months. So that means a not very relevant exposure to chemo is impacting very much in PFS and survival. In fact, look at that. The exposure to osimertinib is much longer as a median as compared to the control arm. It's about 10 months more exposure because you're controlling the disease for longer time. I think that is very relevant data. If you look at the side effects, of course, you're getting more side effects. You're getting the side effect of OSI plus the side effect of chemo. That means the side effects are different, particularly during the initial 3 months. After 3 months, when you're stopping chemotherapy, most of the side effects are actually very similar. And indeed, that is related, that is very well reflected on the quality of life. So that initially there are some more asthenia, some more anorexia, but that is only happening in the initial few months. Secondly, the rate of withdrawal of osimertinib because of the toxicity of the combination is not high. It's very similar to that what you see in the osimertinib alone arm. That is true not only in the late months, but even the initial months, the rate is very similar. So that means chemo is not forcing you to withdraw osimertinib during the combination treatment. The third approach we have seen is the combination of a third generation TKI, in that case, lazertinib plus amivantamab. Amivantamab is a bispecific monoclonal antibody that is inhibiting EGFR on the one hand and MET on the other hand. And you know, this inhibition is made by binding on the external domain of the 2 receptors, and those are very, you know, there is an important crosstalk between MET and EGFR, and the result of the trial have shown that there is a clear improvement in PFS in favor of laser plus amivantamab as compared to OSI alone with a hazard ratio of 0.7. Indeed, that is happening regardless the patient is having or not brain metastasis. To start with, even the hazard ratio is similar in the 2 cases, about 0.7. There is no more benefit as we have seen with chemo plus OSI in the FLORA2 study. PFS, we now have quite, I would say, mature survival data. Again, very similarly to the FLORA2 study, improving OS very consistently. You avoiding 1 out of 4 deaths, treating the patient with AMI plus lazertinib. And importantly, most of the patients seems to benefit across the study. Indeed, 75% of the patients in this trial, regardless the study arm, they received further treatment, and in most of the cases, chemotherapy was the basis. Remember, patients were not allowed to have crossover in this trial. If instead of using a MET monoclonal antibody bispecific such as amivantamab, you're using a TKI, is been proven on a small trial, the combination of OSI plus the TKI inhibiting MET, in that case, savolitinib, you're getting very reasonable response data, I would say, in the range of even 90% when you're using OSI plus savolitinib, and the early data on PFS are okay, but not overwhelming. Indeed, I like to point out in this slide what are we getting today. So you're getting here FLORA, osimertinib, standard of care. What you're getting is more or less PFS, median 20 months and survival, a bit more than 3 years. But if you're using chemotherapy plus OSI, FLORA2, or you're using laser plus amivantamab, you're actually improving PFS. Looking at the data, you're getting more about 2 years PFS. Actually, it was a bit better on the FLORA2 as compared to the Mariposa, and particularly you're improving survival, and maybe survival is in the range of 4 months, 4 years with chemo plus OSI or laser plus amivantamab. So to me today, combination is the standard of care. I may use with some patients OSI alone, but today combination is the standard of care. In those two strategies, chemo plus OSI or laser plus amivantamab have shown in randomized trials to be better. So my default would be combination treatment for my patients. Of course, I will discuss with the patient the pros and cons, improve survival, improve PFS and other things, but you're getting some more toxicity. That is particularly relevant to show the type of toxicity and also the what is the expectations for the patients in terms of depending on the prognostic factors. We know those patients with high tumor burden, with exon 21 mutation, with brain metastasis, they do worse as compared to patients with low tumor burden, exon 19, those without p53 mutations and so on. So I think we have to commend those cases, but always the default strategy should be combination, not the monotherapy. So the other thing, of course, we have to see is how much access you have to those drugs. In my country, as yet, for example, actually in many places in Europe, amivantamab is not yet reimbursed in the first-line setting, and that is important. And also, of course, convenience and toxicity for the patient are, of course, very important. Another issue that you have seen is that another strategy that other people are taking is, well, we have seen that in the second and third line setting, after third generation TKIs, and even after chemotherapy, some ADCs having topoisomerase 1 payloads are pretty effective. So they have taken those ADCs with a chemotherapy payload and they have combined it in initial trials in the third line setting. I'm just putting here one example of the EGFRm plus osimertinib combination trial in untreated patients at World Lung Cancer 2025. Dr. Zhu presented those data, and the response rate was pretty astonishing, 85%, and of course, duration of response was not seen at the time, but you see that the number of progression is really, really very small. Couple of patients, no more than that. There are some other data with other agents being produced, such as with patritumab deruxtecan plus OSI and so on. Of course, if you're combining here, you're getting some toxicity. You know that this agent, this is a bispecific ADC binding to HER3 and EGFR with a topo-1 payload. Myelosuppression is the main toxicity, but as you see here in this combination trial with osimertinib, febrile neutropenia was not observed, and very few patients were actually treated with primary G-CSF, I have to say. Discontinuation rate was very low, less than 1%. So I think the combination is reasonable. So remember, the standard of care is combo, chemo plus OSI, FLORA2, or laser plus amivantamab. I think you have to discuss pros and cons with patient and toxicity, and for some patients, maybe OSI alone would be an opportunity. Of course, some other studies is being proven, replacing chemotherapy on the FLORA2 trial by a potent ADC, and some of those trials are ongoing. A relevant question is, what are the differences in terms of mechanism of resistance between using combination as compared to OSI alone? Well, you're using chemo as plus OSI, FLORA2 as compared to OSI alone, you see that the type of resistance mechanisms are very superimposable. No main difference. If you compare to the Mariposa trial, what you see is less MET-driven resistance mechanism, and that means less MET amplification and less EGFR-driven secondary mutations, so less T797S type of mutations, and of course that may be relevant into the future depending on how you're going to treat your patient. So what is the best treatment after progression, you may ask? Well, today, the more reasonable thing would be to treat patients depending on the mechanism of progression. We know that about 10-15% of the patients are developing some tertiary mutations, such as the C797S mutation, and a number of fourth-generation TKI have been developed in this setting. Unfortunately, those agents so far have not been very effective in the clinical setting. There are some new generations that are being tested, so we are awaiting those results. Some 15% of the patients developing MET amplification, particularly treated with OSI or chemo-OSI. For those patients, a reasonable thing to do would be to add a MET inhibitor, and indeed we have seen data with OSI plus TEPO plus osimertinib, for example, with very nice response rate in the range of 50%, and I would say a reasonable toxicity profile. We have seen in those studies that overall survival is about 18 months with 6-month PFS. When you're using amivantamab in combination with osimertinib post-OSI progression, you see responses on some more than 35% of the cases. If you're using OSI alone, you see responses in some 30% of the cases. And importantly, some small analysis suggested that you actually look by the expression of MET on those patients progressing to osimertinib. If the expression is reasonable there, the chances of your patient to respond is about 90%. Of course, this is based on a small sub-analysis of a phase 2 study, but if those data was confirmed, I would say that would be a reasonable way to select our patients. I have to say that in the past, immunohistochemistry has not been the easiest to validate biomarker for anti-MET therapy. If you post osimertinib, there are strong data now with amivantamab in combination with chemo. Of course, this is post-OSI alone, not post-OSI chemo, but the data were very clear improvement in PFS for those patients treated with chemo plus osimertinib as compared to chemo alone. You see here with a hazard ratio of about 0.45, that means you're decreasing more than half the progression rate at this stage, and that was again true not only in systemic but also in CNS progression, so you're avoiding progression in the brain as well. Importantly, in this trial, there was a third arm where patients were not only treated with chemo plus amivantamab, but also lazertinib, and indeed we have seen the result of inhibiting treating with chemo plus ami alone or chemo plus ami plus lazertinib is not improving the result. So complete blockade of EGFR is maybe not needed in this case. As you see here, you're not further improve the PFS or OS, so I don't think we should use it. Again, the survival data are not yet fully mature, but analysis so far suggesting that there is a an improvement in OS consistent with increased response and increased PFS in those trials by using chemo plus AMI as compared to chemo alone. Indeed, some other events have been shown here, improved PRO as well. It is clear with increased time for sustained deterioration and better maintenance of the physical functioning by using chemo plus amivantamab in those trials. That is very interesting because in the Mariposa 2 trial, continuing with a third generation TKI was not needed. You were using amivantamab plus chemo. But in this compelled trial, which is a small trial on only 100 patients where post-osimertinib patients were randomized to receive chemo alone versus chemo plus osi, you see here a clear improvement in OS, in PFS, with a hazard ratio of 0.43, and that translates into a clear improvement in OS in this small trial. That is not statistically significant because of the small number, but the numerical effect is very clear, improving. So that means if you're using chemotherapy alone, adding on osimertinib on patients progressing to osimertinib may be a reasonable thing. We had some observational data from other studies. This label is not so far clear in most of the countries, particularly in Europe. But some of our colleagues in the US are already using that for many years before the compelling study. Other studies have been using adding on to chemotherapy different agents in the post-osimertinib setting. Immunotherapy with PD-1 inhibitors is not effective. We have trials with atezolizumab, with nivo, with pembro that were negative. Recently, last year at ASCO, we have seen the result of the Harmony A trial. And as you remember here, those were patients that with non-squamous histology that had, in many cases, prior exposure to EGFR-TKI. And you see here that in those patients, there was a clear improvement in PFS, and that was true regardless of the type of mutation the patient had, and regardless the patient had or not at baseline brain metastasis. Remember, the hazard ratio was pretty astonishing in the range of 0.46. So you're decreasing the rate of progression all along the study period in more than half. And importantly as well, the response rate was somehow a bit improved as well, 50% as compared to 35%, but the survival data were not clearly improved in this Chinese trial, I would say. Safety profile was as expected, some more the typical immune-related side effect of a PD-1 inhibitor plus, in addition, some mild effects typically associated with anti-angiogenic effects. Remember, this agent, ivonescimab, is an inhibitor of PD-1 plus VEGF. Now, our World Lung Cancer Dr. Zhu presented us the Harmony trial, not the Harmony A, but the Harmony trial. Sorry for this mistake here, this typo. That was a global trial, some patients from East Asia, from patients from the rest of the world. There was a very consistent data in terms of PFS, hazard ratio 0.5, and the data concerning OS were, again, suggesting some improvement, but not fully statistically significant. It's important to say that here there was some imbalance of the maturity of the Western patient population as compared to the East Asian population. So I would say, at least concerning survival, the jury is still out about the role of ivonescimab in addition to chemotherapy. Well, some other agents are having activity in this setting, and we know that ADCs are effective. Some of them are effective in the post-OSI and post-chemotherapy setting. We know that, for example, patrideruxtecan, which is an ADC directed to HER3, is pretty effective with responses in about 30 to 40% of the patients. We know that from the initial trials with that, and also from a phase 2 establishing the dose with responses in about 30% of the patients. There was a phase 3 trial presented at ASCO where patients were given in the post-osimertinib setting, and here there was a comparison between patrideruxtecan at the standard dose of 5.6 milligrams per kg as compared to chemotherapy. As you see here, there was a significant improvement in PFS with a hazard ratio of 0.77. However, that does not translate into an improvement on overall survival. And of course, based on that, I don't think the drug is being approved, at least in most of the countries, I would say, if not all. Some other agents had also shown activity in this setting. We have talked about this BO1BD agent that had been EGFRm shown clear activity in the first-line setting, but of course as well in the post-platinum setting with responses in some 63% of the patients. And as you remember, myelosuppression is the main side effect, apart from some anti-EGFR rash, diarrhea, and mucositis. I'd like to remember you as well those data presented at ASCO from the sacituzumab tirumotecan ADC. This is another TROP2 directed ADC that is being compared to docetaxel in the third generation TKI post platinum-based chemotherapy setting, and this ADC was compared to docetaxel, and you see here a clear improvement in PFS and OS in this setting. And I have to say this drug is having a phase 3 as compared to chemotherapy, platinum chemotherapy in the post-osimertinib setting, and those results will be presented in next ASCO in the next ESMO meeting. I have to remember you that another TROP2 inhibitor, datopotecan deruxtecan, have shown clear activity in this setting in the TROPION-Lung02 and Lung04 trial, with responses in about 40% of the patients already had received third generation TKI and chemotherapy. So at the end of the day, I just also like to remember you another thing, which is today the standard of care is combination, OSI plus platinum-based chemo or AMI plus lazertinib, and some patients will be treated because they prefer it osimertinib alone, and depending on what you're doing first line, of course, the sequence of treatment is gonna vary somehow, and that is something that you may have to reflect in your discussion with your patient when you're having the initial decision, what is going to be the frontline treatment, what is the type of side effects and overall survival benefit you're expecting from each therapy at each given time, and I think that should be fully discussed with your patient. So I have to say today, the first-line treatment paradigm has changed to date in non-small cell lung cancer, driven by EGFR mutation. We know that combinations is better as compared to third-generation agents alone. We tend to use with combination with FLAURA2 regime chemo plus OSI, or I think the combination of AMI plus lazertinib is another alternative. Some patients may prefer osimertinib, and I think it's fine, always that they fully understand the implications in terms of efficacy and toxicity. Unfortunately, we didn't have good biomarkers today to decide which patient should benefit more from a given therapy as compared to others. We know that some patients, for example, with p53 mutations or with baseline high levels of ctDNA, they are doing worse, or patients with exon 21 mutations, but this is a prognostic factor. Today is not being clearly shown that this is a predictive factor, and a different therapy should be chosen depending on that. And I think it's important. ADCs are promising drugs in this setting, not only in the second and third line setting, but also maybe in the first line setting in combination with osimertinib. And some studies are ongoing trying to refine the treatment in this setting. This is all I have to say today. So thank you very much for your attention. I'll be happy to answer any question or discuss any controversial points I have maybe providing to you during my dissertation. Thank you.
Thank you, Dr. Luis. That was a fantastic presentation as always. And I think you have covered right from all the aspects right now. The most interesting thing that I liked about your presentation, you did talk about the use of OSI as a single agent. That's the same question we asked. 3 years back, we were telling everybody, look, we are doing a test. We will avoid chemotherapy for you. We'll give you just a pill. And now, full circle back, we are saying, look, we are going to give you chemo, but we'll also add a pill. So it's nice the way the whole wheel has turned around. That's very interesting. We do have a couple of questions that I think I can discuss with you before we start the panel discussion. So I think the first question was from Santosh. He wanted to ask, how do you decide between the OSI, the FLAURA2 versus the amivantamab approach? And I think you did say that for you, the P53, the co-mutation and all is the main point. Anything else? How would you like to decide between the two?
Well, I have to admit that today, amivantamab is only available in trials. It's not available in the third line setting in my country.
Okay.
I have to say we do not have a clear predictive factor for FLAURA2 nor for AMI plus laser. We have actually prognostic factors. We know that if your patient is having p53 mutation, exon 21 mutations, high tumor burden, brain metastasis, their outcome is worse as compared to patients without those bad prognostic features. However, I do not believe patients with bad prognostic should be treated with chemo, and patients with good prognostic factors should be treated with OSI alone, because the benefit is the same. It's the same in terms of hazard ratio, but the absolute benefit is much higher in those patients with good prognostic feature. So it doesn't make sense that I'm treating a patient with a p53 with chemo plus IO, with chemo plus OSI, and a patient without p53 mutation, I'm not offering chemo because this patient is benefit a lot more as compared to the other. So I tend not to look very much to prognostic factors to choose between chemo plus OSI or AMI plus laser as compared to OSI alone.
Fantastic. I think that's where we came. Like I said, we have come around that you should add chemo to everybody. So it actually makes the job a bit easier. You start off the chemo and then add the OSI if needed. It becomes slightly easier for us as it goes forward. Dr. Ashish has asked a very interesting question, which I also wanted to ask you. We do encounter this situation where you have EGFR treatment, you don't do a biopsy, but you simply do a liquid biopsy and you find that there is no EGFR found. So how do you react to that? You just simply go ahead and give your amivantamab as second line, or how do you decide your second line?
So what I'm typically doing is I try first post-OSI and try first a liquid biopsy. If the liquid biopsy is, let's say, you have two possibilities. One is that is non-informative. If the amount of tumoral ctDNA is less than 1%, I take that as a non-valid result, similar to not having done any liquid biopsy.
Oh.
And then I try to do a solid tumor biopsy before deciding my next treatment. So if if in the liquid or in the solid biopsy, I see a targetable mutation such as, imagine an ALK fusion, a RET fusion, a KRAS fusion, a MET amplification, then I give typically targeted treatment in combination with OSI. If not, my treatment typically post-OSI, if I'm able to do post-OSI Mariposa, and try to do Mariposa. And we have seen that the combination of OSI, of chemo plus amivantamab is improving results, and I intend to do it. If I'm not, let's say, having not access to amivantamab, I think putting chemo plus osimertinib could be my best alternative, particularly if I'm worried my patient is going to have brain metastasis. Going on with osimertinib is particularly relevant to avoid brain metastasis to develop. Of course, you need to have reimbursement of this osimertinib plus chemo, which is not always there. Yeah, I mean, I have to fight each individual patient with the insurance in my country because there is no official reimbursement because the data are not very robust. It's based only on data such as the compelled trial and so on.
Excellent. So for us, it's the other round. They cannot afford, we just give it up from there. Our insurance is slightly different, but so this is what Santosh is in fact asking. How do you manage co-alteration? So I think that's been answered, Santosh, that you would just add both together. So I think in the interest of time, let me just call my other panelists and we can go ahead with the discussion. So welcome to Dr. Sai Vivek from Bangalore, Dr. Prasad Narayanan from Bangalore, Dr. T.P. Sahu sir from Bhopal, and finally Dr. Ashish Kaushal from Ahmedabad. So, of course, Dr. Luis, I would love to have you please continue with us for some more time while we discuss this cases. Very simple cases, and I think we have discussed a lot of the issues here. Can we have the slides, please? So what I'll do is just give a couple of examples of the slide of the cases, and then we will discuss certain issues that have already been decided. Next slide. So the case one, next slide. Next slide. So the case one is a 65-year-old male, non-smoker, cough with pleuritic chest pain, left lower mass, pleural thickening and effusion, multiple brain lesions, bone lesions, clear-cut adenosia. Next slide. So biomarker testing, I think this was a discussion we used to have 5 years back. I don't think there's any patient in the country where we would not do a biomarker testing by NGS. It's just that we would possibly change the pattern based on our own number of patients, etc., based on the affordability and cost. But I think there's no patient where you wouldn't do a testing. Dr. Prasad, I think that's the way now.
Yeah, I don't think anywhere in any setting we are having a patient who doesn't get a biomarker test, right? All the patients get, most of the time they get at least a limited NGS is almost standard for all patients.
Fantastic. I think in my setting, almost 100% get it. Only either mostly a solid the biopsy, if the biopsy inadequate, at least a liquid we do for everybody. Dr. Sahu, do you agree that that's the situation today in India? We do for almost everybody.
I totally agree. I think except in I don't think anyone is not getting NGS done.
A logistic issue, patient comes and disappears the next day to go home. I think that's the situation where it won't do it. But as a choice in India, I don't think there's anybody we don't do an NGS. Excellent. Dr. Ashish, you're comfortable with the liquid biopsy? You're comfortable saying if you cannot do a solid, you're fine with doing the liquid, or would you keep repeating a biopsy till you get the tissue?
No, I'm fine. If the tissue is not sufficient, I would prefer to getting a repeat biopsy, but otherwise liquid is also.
Perfect. I think, but this is pretty much clear for every one of us. We do a tissue as much as possible. If not feasible for any reason, we are fine doing a liquid as well. So how do you approach a patient of metastatic NSCLC while waiting for the report? And here it, of course, also boils down to what is the time you're taking. So Dr.
Can I ask Dr. Lewis one particular thing? So in your practice, do you do both? Because there is enough data from the Nile that you add another 10% of the mutations. So do you do both liquid and solid? As normally what we do here is we do the solid, and if that is done, we do have that. We do not have you proceed forward. So do you make it mandatory in your practice to do both so that you do not miss any form of mutations?
So let's say what I'm doing is the following. Let's say at baseline, I'm doing always NGS solid by default. If my patient, if I don't see any result, any actionable mutation on the tumor NGS, if my patient is a light smoker or never smoker, then I do in a liquid. Because I have seen that with informative tumor biopsy in never smoker or low smoker, in 15% of the cases, I'm finding a genomic aberration suitable for targeted treatment. At the time of relapse, I tend to do first the liquid, and if the liquid is informative and telling me, let's say, there is a meta amplification, I treat it accordingly, and I, somehow save my patient to have a tumor biopsy. If it's non-informative, I tend to do that. In the only situation I'm going first at the relapse for a solid biopsy is if the patient is suggesting to me clinically to have a small cell lung cancer transformation. Let's say if there is a predominantly progression on the mediastinum, if the disease is going very fast and so on. In that case, I may go first to solid as compared to liquid.
So, Dr. Lewis, can I ask a practical aspect in this?
Yeah.
We do send a solid biopsy. We wait for, say, 7-8 days. You have to wait for the result. You may tend to start the chemotherapy and then you get a result saying nothing. Would you be able to then send a liquid biopsy again? Because, post chemotherapy, the liquid biopsy results are, we don't know how accurate they are. So,
Honestly, I prefer not to start any treatment unless I get the result. But I'm a bit lucky on that because my pathologist, when they receive the biopsy, if it's let's say a non-small cell lung cancer, they immediately do a default NGS. So when the patient is coming to me from sent by pneumologists, in more than 90% of the cases, I already have the NGS result. So I
that's
don't
fantastic.
have to, in fact, what they do, the pneumologists, the very day they start they do the biopsy, they start my patients on vitamins, just in case they are having an adenocarcinoma that they need chemo. So in that case, that is something that we have pretty well protocolized. So when the patient is coming to us, I typically have the NGS, the patient is already on vitamins, so I may start treatment next day.
Wonderful. So can I ask you, what's the time from the biopsy to getting the NGS result? Is it 1 week, 10 days, 5 days? How many days is it approximately for you?
So I would say that fortunately had improved a lot. So today is in the range of 8 days.
Wow.
I would say most of the patients between 7 to 10 days.
Okay.
If I need to have an urgent result, I call the pathologist. I always have it in less than 72 hours.
That's fantastic. That is awesome.
That is, if I need to it's a bit more expensive because, you don't have maybe some, I mean, the kit is not fully filled. But anyway,
Sure.
if you have in an urgent case, you always have it.
So let's ask in India how much is. So Dr. Saivek, how many days from the diagnosis, that means you got pathologist says this is NSCLC, to getting the NGS report? What's your average time? Sai?
I was muted. Yeah, I'm sorry,
Yeah.
sir. Yeah. So it varies again from which lab we are choosing. I think in India, a lot of them are coming up with this process of saying, we'll give you the results in 5 days. But certain labs do offer it in 10 to 14 days. But majority of them, I would say 3 to 4 weeks.
3 to 4
That's
weeks.
the 3 weeks. 3 weeks, I think, is the majority. But there are people, if at all you're able to pay for it, you can get it in 10 to 14 days, I'm guessing. Yes.
Okay. Dr. Ashish, your experience?
Yeah, we are done in locally, so I think 7 working days is max.
7 working days is your time. Okay. Dr. Prasad?
I think maybe 7 to 10 days.
10 days. Okay.
Yeah.
So I think Dr. Sai Vivek, you're stuck with the Bangalore traffic, whereas Prasad being in the outskirts of Bangalore gets it done fast. Dr. Sahu?
So I go with Sai. Somehow it's taking 15 to 18 days. I think it
Yeah.
goes via Sai's hospital. So it's better.
All right. So
Okay,
for
can I
those,
ask Dr. Lewis one more quick thing?
yeah, please.
There is a lot of talk on what panel would you choose? The limited panel 12-15, which is ASCO recommended for what you have a drugs for, or and this I'm speaking for the patient for newly diagnosed. So would you go for a broad panel, or would you go for a limited panel 12 to 15 genes which you have drugs to target?
You know, I tend to prefer, if possible, to go with a large panel. So the standard of care we are using is 50 genes panel.
And may I ask why? What is the advantage for a 50 versus a 15 if the
Yeah.
depth and the reads are equal?
So the issue for that is, you know, we have a relevant a clinical trials portfolio. So let's say if my patient is having a LKB1 mutation, it's somehow giving me extra information. If my patient is having an MTAP mutation, I may try to go another path instead of going to chemo alone. So it's giving some opportunities. Indeed, so very often, you know, when we are having some of those trials, for example, with NTAP or so on, I'm actually asking the sponsor of the trial to pay me the difference between having a 52 genes versus having 300 genes. And if they are covering me the extra cost, I try to do a, you know, maybe 350 genes as compared to the 52 genes.
So to give the option of opting the patient for a clinical trial, that's what
Yeah,
you
yeah, that is the main, yeah.
Dr.
Oh,
Sahu,
got
if I
got
can add to it, I think the discussion is different for a practicing community oncologist and a specific center. Because if you're in a specified center, you can ask for which genes you want tested. For example,
Understand.
the
Understood.
panels that we want, keep and STK, if I want, I have to do a 216 panel because that's what the company is offering. So I think that's the difference. If you want to, the reason we offer sometimes a 506 gene is just to get the TMB and the MSI and stuff like that, which you won't get in a 12 gene panel. So it's individualization that really matters. So next slide. So again, the reason why this whole discussion is that do people wait for it? There was this testing when we had, there was a testing based on the, from a paper from Dr. Kumar et al. And they said that people in India mostly wait for the results. And I think again, by and large, most of us would wait just because we are aware that 10 days, 12 days is not very bad for a PS1 patient. For those who are sick, we would start with chemo. Is that okay, Dr. Sai? Do you agree with that
Yeah,
statement?
I
Okay,
agree,
Dr.
sir.
Yeah. So I think in practice, many of us might tend to start chemo. And again, that's not wrong because you are having a kind of a intention in terms of the disease and in terms of the volume of the disease, in terms of symptoms. You may need to start sometimes treatment beforehand. The next slide, please. The reason why this is again brought out that there was this paper which actually says there's a compromise outcome if you do not start TKI as per the result. Now, again, a bit of a, I should say, headline statement because, you know, the trial looked at, next slide, please. They looked at 35 days as the cutoff and said that within 35 days, you need to start the TKI. So I think all of us are well within that. Even the Bangalore traffic will get you within 15, 20 days. So, you know, you're not so far behind. So I think that's something we have already dealt with. So this patient did have an adeno-CA and and had an EGFR positive. Obviously, we are discussing EGFR today. So he had an EGFR exon 21 L858R, non-smoker. So next slide. Let's start off one by one. Dr. Sai, your choice.
In him, I would go for OC plus chemo if the performance status is good, sir.
Performance is good. All people in
Yeah.
AdWords always have, all people
Done.
always have perfect TS, right?
Done. OC plus chemo is what I would go for.
Dr.
Yeah.
Prasad.
Yeah,
Awesome plus chemo.
definitely.
Okay.
Liver mets at presentation, they will give
Brain
chemo
mets.
with
Excellent.
TKI.
Dr. Ashish?
Yeah, similarly, but this patient also has the brain
Brain
metastasis.
mets, correct. That's
So
the
if it
reason
is
why.
symptomatic, then we'll definitely like to treat with SRS.
Okay, I am a big fan of not giving SRS, especially you have osimertinib there, but okay, point taken. If very symptomatic, you might want to radiate that brain met. Perfectly fine. Dr. Sahu?
If symptomatic, I go for a radiotherapy. That's how I practice, and I would go in this case for a OC plus
Okay.
chemo.
So just Dr. Lewis, your thoughts on, brain RT, especially whole brain, does cause cognitive dysfunction, especially when the patient lives for 2-3 years, as you expect nowadays. So should our threshold be a bit low for brain RT now, or I mean, should be a bit high for brain RT, or what's your thought on that? How often are your patients getting brain RT in brain mets nowadays?
I mean, ollocranial radiation, I try to avoid it. So what I typically do on a patient like that, I would start chemo plus OSI. And then, after response, I would discuss with my patient about the need or not to do a SBRT. I wouldn't do holocranial radiation, I wouldn't do it. We know those patients today are having an expected median survival of maybe in the range of 5 years or nearly 5 years. So, I wouldn't risk to irradiate my patient from baseline. That would be a too high risk for cognitive deterioration at some point. Very often, I mean, at least some of those patients are still young, not all of them, but some. So I would try to avoid it. Maybe, there are some data, not very robust, but some data suggesting that consolidating with SBRT, if possible, if a small number of lesions may be worth it. And that is something I'm discussing with my patients.
Fantastic. So a couple of good, interesting things. Ramucirumab, there's a lot of data saying that, you have Ramu, give, especially in L858R, it helps. I mean, I think we are kind of over that by now. Dr. Lewis, your thought on that?
I mean, I think, Ramu and so on, they are fine, but no survival data. So, I tend not to.
Yeah. And
I
again,
tend to
interesting
somehow
from,
disregard.
interesting from our point. We had a lot of discussion last 2 years about the Jeffy chemo, which was actually a very nice study from TMH. And, we used to always debate that is as good as the Aussie monotherapy because Aussie was costly. And then Aussie plus chemo has come along. So at least practically speaking, Dr. Ashish, are we still using the Jeffy chemo in those patients where, Aussie is still a bit unaffordable for a lot of our patients?
Yes, and a lot of patients we are using. Because in India, the cost is one of the major concern. Most of the patients paying from their own pocket.
Correct.
So that definitely is matter.
Dr. Sahu, your experience, Gefitinib?
I still do it. OC is still out of reach for 80 to 90% of my patients.
Exactly. Dr. Prasad?
Yeah, of course. I mean, many patients get Gefitinib plus chemotherapy.
So I think this is something in India, unique thing. And for me, the confidence of using this regimen actually went up much more when we saw the Aussie chemo data, because it's essentially the same thing. The criticism was, why do you want to combine a drug with a chemo? But now we see that's exactly what has become the standard of care. So in India, I think we still use the Jeffy chemo for a few patients, at least for the affordability issues. And it does work better than only Jeffy. So that's how I'd put it. Next slide, please. So again, we already are aware of the data which has been already shown to us, what is in the first line, second line. So I think everyone agrees that combination is the standard of care for all patients. The only patients where we wouldn't give it would be some cases where they cannot take the chemotherapy, you're scared to give chemo, elderly, some reason not to give chemo, but as a standard of care, you would end up using a combination therapy. Next slide. Next slide. So in this patient did get the FLORA2 thing, and there is a median survival which has been updated and it was already shown.
Dr. Lewis, two questions here.
Yeah.
Dr. Lewis, are you happy with the OS curves? Do you feel a little bit put down and you expected much more? And what do you have to say that the curve crossed each other at 15 months, and that's a good big time. So actually the combination arm was doing much worse. And if you put the PFS and superimposed to the overall survival, I get it from my initial thought that most of the patient who progressed on the combination actually died very early. They did not receive adequate second line, which was shown by what the data also. And actually, the patient on single agent osimertinib with a PFS at 12 months of 60%, 82% or more are surviving. So they actually did go on to receive the second line, which could be a chemotherapy or something, and they did very well. The curves in the initial 15 months, it looks very bad. What is your thought on the OS curves?
Well, I'm a bit, I really would like to understand why there is this crossing of the curves at about a year time.
15 months, actually.
I don't understand because there is no initial increase in progression in terms of the PFS for the chemo-OSI curves. So is that toxicity? The toxicity curves didn't talk about many, let's say, severe events. So I really like to see what is the reason or what are the reasons for dying during the initial 18 months in the two arms. I don't think so far is very clear. So yeah, uh, I would like to understand that. Anyway, this effect is not, I would say, huge as compared to the huge benefit you see after 18 months, where there is a clear separation between the curves, and that is sustained all for the rest of the study. So that is some analysis that we have mentioned to AstraZeneca in several forum to actually try to share with us, dissect pretty well the initial 18 months of the trial in terms of survival, but I don't think we have seen those data as yet.
Interesting, Dr. Sahu, the AMI study also showed a similar thing. The AMI chemo also showed a crossover.
No, I understand, but
So
look
that's
at
the
it,
why.
just a minute, if I can, because we have the expert here. If you look at, sir, at the 12 months, the PF is 66% for the OC alone. And if you look at it and I put the curves, actually, it is around 85% OS data at 12, even for the osimertinib alone. And at 12 months, it is 80% PFS for the combination. Here, it's around 80 plus. So the impression which I get is most of the patients who have failed on the combination actually have died early, and there has been no effective second line. While patients who have progressed to OC alone did get effective chemotherapy, which could have pushed the OS up. Though, and the later part, maybe, I don't know, sir, the ADCs would have come into trials, which probably would have pushed this survival because there were more effective second line therapies post progression to combination therapies. I just have a hunch this could come out. What is your take, sir?
Honestly, it's a bit difficult to me to say. I mean,
Okay,
I
sir.
understand this kind of a
Okay, let's move on. I think let's move on. Next slide. So this patient declined chemotherapy and wanted to go only with osimertinib. So again, we do get such patients and we do use osimertinib. I think that's been our take on it. Would you monitor ctDNA? We are running a bit out of time, so just one person to answer, Dr. Prasad. We don't routinely monitor ctDNA. I think most of our patients. Would you like to monitor ctDNA? I think, except probably certain parts of Bombay, Delhi, most of us are not big fans of
No,
monitoring.
I will not monitor
You will
ctDNA.
not
I don't think that
Next
makes
slide.
good difference.
So I think we go by the standard imaging. ctDNA is nice and experimental. I think it has have its value, but doing for every patient is not easy. Next slide. So why this has come about? Obviously, there is a ctDNA as a prognostic marker from the FLORA2, and like almost everywhere, if you clear the ctDNA, you're likely to do better. And I think that's something which we do routinely. Dr. Lewis, is this done on a routine basis outside of a clinical trial or outside of a, academic institute? Is it feasible to do it as a routine basis for you? Yeah.
Honestly, I mean, actually, this is pretty easy to do for us because we are having this digital PCR, which is once you're having the technology is very cheap, it's not expensive to do so. But honestly, I'm not sure yet that you need that very much for making decisions, because that is just telling you that those patients that are responding are doing better. That is the same as you see in the CT scan. So, I tend to do so on liquid biopsy, particularly when I'm having some doubt. The patient, is having some doubt, is progressing or not, things like that. If not, I don't need to do that every month, I don't need to do a CT scan either every month. So, on the other hand, the only information it's giving you is prognostic information. Those patients that are responding in terms of ctDNA are doing better. That is very intuitive. Responding patients are doing better than non-responding patients. But we haven't seen any data telling you that if you're starting with OSI and then at month 3 patient is not, let's say, clear on DNA, then you may add chemo and it's the same as if you do chemo from the beginning. I don't think we have those data. So that is the reason I don't tend to do it. I don't take a lot of decisions based on that. I just prefer to start with chemo.
Excellent. So I think, like I said, the role might evolve and cost and how do you utilize this report, nobody really knows. You get a report saying 3 CTC is seen and then it becomes 5 CTC. What do you do with that report? Nobody knows. Next slide. Next slide again. So next slide. So I think Dr. Lewis has already completely talked about how the benefit of ctDNA is. This patient had oligoprogression. And again, I think this is a discussion we have had several times. If you have oligoprogression, you would do local therapy and continue osimertinib. Again, an individualized decision, but I think by and large, that's how we would go ahead. Next slide. So again, osimertinib beyond progression, especially if it's an oligoprogression, it does work. There are several studies to show that it helps if you can continue the osimertinib. You wouldn't stop the osimertinib at any point. I think that's the key, unless you're finding a genetic, any reason in the liquid biopsy to suggest a new mutation. Otherwise, you just continue the same. Next slide. Co-mutations, I think we have discussed several times, and we do use combination therapy. As Dr. Lewis said, we would like to combine both the targets. Next slide. Next slide. So this is a second case where a 56-year-old lady, non-smoker, again found a right lung mass with a L858R. Next slide. So this patient was started on erlotinib. So yeah, Dr. Vivek, any questions? Question from
Oh,
you?
no, I was just going to wrap up what Sahu sir was saying. I just went through the data. Flora 2 finished enrolling and in December 2021. And that was the time when Mariposa 2 started enrolling. So sir was spot on when he said people who progressed on the osimertinib plus chemo would have jumped into the amivantamab trial, and you see that curves. So they match the calendar of enrollment, sir.
Sausa knows everything. Excellent.
Spot on. The dates
Like I
match.
said, Sausa reads a lot and is very smart.
Yeah.
Okay, so this lady is a patient who was started on erlotinib. I think by and large, we are very comfortable with geftinib for a long time. Jeffy was not available in the US till some time back. So, probably erlotinib was the reason they started. Patient had responded to erlotinib. Next slide. So then had progressive disease, then again had a stable disease. This time it was again a L858R with T790M negative. This being 2023, however, patient did continue only carbopem and then took a maintenance PEM and declined repeat tissue biopsy. No amivantamab given, probably not in the US then. Next slide. And then a liquid biopsy did not show an actionable alteration, rechallenged with carbopacly, switched to DOSI, and then offered a best supportive care. Next slide. So again, this patient was later seen by somebody else, and that time they offered all these things as a repeat biopsy, clinical trial, or as only osimertinib single agent. Next slide. So this patient was started on a single agent osimertinib and actually had responded well. Dr. Sai, I mean, would you have followed the same approach? I think practically many of us would have done a similar approach, but I think as a want or as a need, you would not have done this. You would have wanted a repeat biopsy. You would have done the amivantamab. You would have gone for something else, right?
Yeah, completely agree. So yeah,
I think that's how it is. One thing which we would look for is the rechallenging. Do you rechallenge osimertinib after a first generation or second generation TKI? I think that's a question we don't really see very often, Dr. Sahu. We do treat a lot of patients with first, second generation even now. So is this really a thing for us that without testing you would jump and give osimertinib?
No, re-challenge of osimertinib, no.
No, I think that's about it. So next slide. So that was
Can I ask Dr. Lewis one
absolutely. We have
small
5 minutes, and so we can ask.
Yeah. So, sir, regarding the compel, if I've got the trial name right, the addition of chemotherapy to osimertinib versus continuing osimertinib. Looking at the data set, the median metastatic sites were around 1 to 2 only. Would that not put forward the oligometastatic scenario which Dr. Vamshi spoke of? So basically, the trial, the median metastatic site was less, only 1 to 2 or maybe 3. So would it make that you add chemotherapy to and continue osimertinib where you have an oligo progression rather than you have a very large amount of progression, then you would like to change over the protocol? So what is your take on that? How do you practice today? Sir, you're muted, sir. You're muted, sir.
Sorry, yeah. I tend to do a local therapy if the patient is having 1 or 2 mutations that I'm easily, and in that case, I'm just doing radiation or surgery and then going on with OSI. For those patients that are progressing systemically, which is not salvageable with local therapy, I tend to do on the standard of care chemo plus amivantamab today. In the past, if amivantamab was not useful, I tend to do chemo, and there was a debate between doing OSI or not. Honestly, the label in my country was not in favor of OSI. Continuing OSI was out of that. I understand many people in the US was doing that based on not very good data, just observational retrospective trials. I mean, the compel data is a small trial, 100 patients, but they suggest, and it's reasonable, that you're somehow controlling a bit better the disease. Is that enough to that we should to provide that new standard of care? I don't think so, to be honest, because as you mentioned.
So the compel had median very less metastatic sites. So it's basically looking towards the same.
This is a very selective group of patients, as you mentioned. Secondly, that makes sense because those are the patients where you really like to be sure that this patient that is going to have better survival is not being jeopardized in terms of quality of life by having a brain metastasis. So it makes sense. But I understand the physician somehow selected the best cases for this trial as compared to those patients with very aggressive disease. Yeah.
Last question. If you had the option and today Spain would approve amivantamab or Mariposa, let's say the Mariposa data set frontline, how would you choose in reality outside being the easy symposium, Flora 2 versus Flora versus Mariposa?
Okay, so if AZ is not here, I will tell you.
No, they are not here.
Okay, I'm telling you. For most of the cases, I think I'm going to use Flora too.
Okay.
The reason being, safety-wise, I think is better tolerated to the patient. We really improve a lot the way we are using amivantamab, honestly. Subcutaneous, dermatological monitoring and treatment, and also all the prevention with dexamethasone and so on, and also anticoagulants. But of course, you needing a lot of treatment to support to have the regime much better tolerated.
Yeah.
On the other hand, the chemotherapy, platinum-based chemo is only for 3 months. Then you're going on pemetrexed. I mean, we have been using maintenance pemetrexed for many years, from 2011. So this is not a big issue for us, for our patients, for the hospital. I think today is much better tolerated. And then still, I think the average number of treatments that our patients are receiving with Flora-2 is 3 months of chemo, 8 months of osimertinib, of pemetrexed. So I think these patients, maybe at the time of progression, I'm gonna use, in many cases, Mariposa-2. I'm gonna re-expose to pemetrexed and platinum. If you know, after more than a year of platinum-free interval and so on, pemetrexed,
you can re-challenge on this.
I'm gonna re-challenge that and add that on amivantamab as well. So of course we don't have the full data to do so, but I think I will do.
And the 858, would you not do single agent osimertinib with that exon 21? Because that data set tells you that they did not do well. Very clearly, 35% patient.
Well, you know, let's say the data, I mean, looking at the data in terms of Flora-2, particularly.
Flora, would you do osimertinib alone for exon 21?
No, I would do chemo.
So I think, Dr. I don't think we are doing OSI alone as a choice in any setting, unless, of course, you cannot give the chemo. I think that's what.
Understand.
Right?
Yeah.
Thank you.
So, Dr. Lewis, one last question from my side. Where do you place ABCP in this whole discussion? Do you think immuno has any role to play in an EGFR mutated, at least as a IO as a IO, what we have now, not the harmony kind of thing, not ivanosemib, but IO anywhere in EGFR positive disease?
You know, I tend not to use much immunotherapy in this setting. I understand that anti-eugenics is part of my treatment at some point. For example, post-platinum, in the past, I tend to use Taxol Viva, not docetaxel. I tend to use Taxol plus Viva. It's a cheap treatment, a lot better tolerated than docetaxel today, and is more effective. So I tend to use it, particularly in those patient population. But I don't know, you know, things are changing. ADCs are gonna come up, are gonna make it at some point in the first line setting and so on. So, I mean, still many things to do.
Yeah, I think the ADCs are going to reach both in terms of our understanding, in terms of pronunciation, and in terms of how to actually use them. So thank you so much, Dr. Liz. That was a fantastic discussion. Thanks to all my panelists and thanks to the audience. Thanks to the Kavina team for hosting this meeting brilliantly. So good night, everyone, and hope to have many more such meetings. Good night.